like to thank you guys for being here, and I think it's a really unique opportunity to have this dialogue. And I love the previous talks so far to where we're at. And what I'm going to spend a little bit of time doing is talking about specific therapies that we utilize for inflammatory bowel disease that involve the nutritional approach. I'm going to talk a little bit about how we approach the family and the patient, and also the data behind if these therapies are effective and for what patient population they are effective. So I have no disclosures. So why do we focus on diet? So if you go to a large inflammatory bowel disease conference or a big gathering of professionals who treat IBD, they will focus on the latest and greatest medications. This is data from a trial called the SONIC trial. It was really a landmark trial. And what this data shows is that it compared an oral medication called azathioprine to an IV medication called infliximab, or the combination of both of those medications together. Okay? And these are all medications that dampen down or suppress the immune system. And the great news here that the papers, the New England Journal of Medicine talked about was this combination of these two immunosuppressive medications is by far the most successful and effective therapy we have. So 60%-ish of people were in corticosteroid-free clinical remission at 26 weeks. And that was celebrated as great success. And in my opinion, that is great news. But when I look at it from a different lens, I see a huge opportunity. I've highlighted in red here, so 40% of people plus were not in corticosteroid-free clinical remission. In my opinion, this is a great opportunity for us to think about other pathways to impact and to think about how we can use diet and other therapies to impact disease outcomes for inflammatory bowel disease. Good opportunity for us. So why do we focus on diet? We know that medicational therapy is an important part of the paradigm for treating IBD, but it is not effective for all people. Okay? We know that patient beliefs, there's been phenomenal sort of data published, case reports, anecdotes suggesting and demonstrating that dietary therapy makes a big impact for folks. And I will go through some of this data. There is some risk with immunosuppression. So immunosuppression means that you're dampening down your body's innate immunological functioning. So our immune systems are designed to fight off infections and to surveil for abnormal cells. In the setting of inflammatory bowel disease, our immune systems are too revved up and they do not shut down and become quiet after they've been initiated to start activity. And then I mentioned, so diet supports efficacy of primary therapy. Dr. Suskind has described the specific carbohydrate diet. I'm going to do a little bit of a lay of the land of other exclusion diets that have been studied and also focus some on exclusive enteral nutrition, which is a formula-based approach. So I think we as a group here have established that diet is important. I want to describe a little bit more of sort of the land of the data out there that is supporting that diet is important to focus on. So if you look at epidemiological studies, so large population-based studies, and you look at dietary exposures, there's clearly an association between dietary exposures and the incidence of developing inflammatory bowel disease. Okay? Immigration studies are also quite interesting. So when you migrate from one country to another country, your genetics don't change very rapidly. But interestingly, the kids of people that immigrate, if they immigrate to a country of higher disease risk for IBD, their kids take on that higher risk. So again, the genetics are not shifting rapidly, but environmental exposures are, suggesting that diet and other environmental exposures play an important role. And then we're going to talk about exclusion diets and the data behind how these are effective as therapy for IBD. All of these things, in my opinion, point to this idea that Western culture, the Western diet, is something that we need to study better and understand better. So some described risk factors from epidemiological studies include greater saturated fat intake, total polyunsaturated fatty acid intake, omega-6 polyunsaturated fatty acid intake, and meat. These are all risk factors for developing inflammatory bowel disease. There are some dietary protective factors that have been described as well too. Fiber in general, fruits and vegetables, and then omega-3 polyunsaturated fatty acids. These have been associated with decreased risk of developing IBD. So the objectives of my talk, I'm going to first review the process of discussing nutritional therapy with the patient and family. It is really important to engage a family with whichever therapy you're going to employ, but in particular, diet has a really profound impact on family and patient dynamics. Next, I'm going to discuss the data supporting exclusive enteral nutritional therapy. And then finally, I'm going to discuss the use of specific carbohydrate diet in clinical practice, which is going to be a lead-in to Heather Twible and also to Tali Godet, who are going to also really describe much more hands-on how this is employed. So first, how do you discuss nutritional therapy with the family? This is a case here. We have JW, and he's a 14-year-old male, and he has newly diagnosed ileocolonic Crohn's disease. So it involves a small bowel as well as a colon. And his presentation was 20 pounds of weight loss over 6 months, and he also had significant diarrhea. Interesting family history. So maternal grandmother and also mom have a history of lymphoma that has fortunately been successfully treated. As you can imagine, the family is wary about the risks with immunosuppression because I did mention increased cancer risk, and they are curious to talk about what are the different therapeutic options for inflammatory bowel disease treatment. So in thinking about if nutritional therapies are appropriate for your patient, there are a few things to think about. First, what is the IBD phenotype? Meaning, what type of IBD is this and where is the location of disease? Next, is the patient or family actually interested in nutritional therapy, or am I, as the doctor and dietitian, pushing something that they don't really want to do? And finally, what are the expectations for nutritional therapy? I think very important to set expectations early. If not, I think it leads to a lot of confusion, poor follow-up, and potentially poor alignment in sort of implementing therapy. So first, ulcerative colitis versus Crohn's disease. Many folks in the room are quite familiar with both of these conditions. I'm going to briefly review. Ulcerative colitis is a form of IBD that is isolated to the colon. It starts in the rectum and then is confluent inflammation going upstream and is isolated only to the colon. Crohn's disease is inflammation in the GI tract, but this can be patchy involvement of any part of the GI tract from mouth all the way down to the anus. Okay? So medical therapies in general are very similar for ulcerative colitis and Crohn's disease. Again, medical therapies involve suppressing the immune system. There are some immunosuppressive therapies that are more beneficial for one type of IBD than the other, but in general, many therapies, corticosteroids, infliximab, adalimumab, azathioprine, methotrexate, they are frequently employed for both UC and Crohn's. There are some key distinctions for UC and Crohn's. The type of surgery that you might consider for either of these conditions is different. And also, there is data suggesting that there is differential efficacy for nutritional therapies. Dr. Suskind mentioned SCD being efficacious for both UC and Crohn's. Exclusive enteral nutrition, though, is not quite the same story. I'll talk about it in a moment. So by IBD phenotype, so Crohn's disease, exclusive enteral nutritional therapy works. So this is a dietary approach where you do formula only and you exclude foods. Specific carbohydrate diet also works. Ulcerative colitis, exclusive enteral nutrition, it does not seem to work at this point in time. Further studies to be done. We do know specific carbohydrate does work though. There are some unique scenarios where you have to kind of be a little bit nuanced in your employment of dietary therapies. So for example, if you have Crohn's disease that involves inflammation around the anus, you might not be the best candidate for a nutritional therapy approach. If you have fistulas, which is compromise of the bowel wall and leakage of bowel contents across that, you have to be careful about which dietary therapies you use. And finally, if you have a stricture, which is a narrowing of the bowel wall and kind of a scar that forms, making it difficult for food and stool contents to transmit or to transit through the GI tract, you have to be mindful about employing dietary approaches here. So, patient and family interest. So, a lot of times in Dr. Suskind's, my clinic, and I'm sure in quite a few of your clinics, folks will come to you and ask, after the diagnosis of IBD, can you tell me about the different medicational therapies and the nutritional therapies? Okay? So it's important from my standpoint that at that initial discussion, when you're talking about therapies or changing therapies, that you are pretty open and honest about the different medical therapy options, the pluses and minuses, as well as the different nutritional therapy options. And there are pluses and minuses to both approach. We have to understand concerns, motivations, and expectations. And then there's this interesting child-parent dynamic that we have to be mindful of, and I'm learning about with my young kid. So expectations, I think important to establish this framework. Inflammatory bowel disease is a chronic disease, implying that you will require lifelong therapy of some sort, be it medications, diet, or other. I think sometimes we tend to minimize that dietary therapy is a rigorous intervention, but dietary therapy is phenomenally hard work. And I think Heather and Tali Goudet and our panel are going to talk to you a little bit about. The goal is to not make it hugely, hugely burdensome, but this is more work than taking a pill once per day. Okay? The other thing we have to really establish, if you're going to be on dietary therapy, yes, you're doing a lot of the heavy lifting at home, but it is extremely important to partner with the medical team, your physician, your practitioner, your dietitian, to monitor for disease activity and also for nutritional adequacy. We have learned over time that you can have improvement in your symptoms with nutritional therapy, but you can have ongoing inflammation. And that is a problem. You really have to get to the bottom of treating the inflammation in addition to the symptoms. So, another part of the expectations to establish. So you have to say dietary therapy is phenomenally effective for some folks, but it doesn't work for other people. So if somebody says, there is no way I'm going to be using these toxic medications, you as a practitioner, it is important to say, we can partner with you to use nutritional therapies, but these may not be effective. We will follow your response to nutritional therapies, but if not effective, we need to have the immunosuppressive medication discussion. Important to establish early on. Okay? And one thing that we've learned over time is some people will initiate nutritional therapies, and it's wonderful, but there is some ongoing inflammation. In those situations, an important concept is you can continue your nutritional therapy and perhaps layer on some additional medicational therapy, okay? So this layering on approach, the additive approach to therapies, and perhaps this can make it so that you have better outcomes with your medicine plus diet than you would have on your medicine alone. Okay, my approach. I try to be honest with folks, and I say nutritional therapy is something that we have strong interest in studying. The data needs to continue to grow here. We think it works for quite a few parents and patients, but it is important that we monitor closely and we think about next steps and have a plan B if things aren't going well. Okay? I really make it a point, and this is where I'm thrilled that we have multiple dietitians from our GI division here. We have 3 dietitians sitting in a row. We partner with our dietitians because this is really difficult therapy to learn at first, okay? You're flipping your kitchen upside down, and some families are like, I don't know what to cook for my kid. Can I feed them the same thing every day for a week, and is that gonna be okay? It requires close partnership with a dietitian, and the dietitians are far superior to us as the doctors in helping to guide implementation of this, okay? I make plans for very close follow-up, so follow-up within 2 weeks, a month, for close checking of objective markers of inflammation. And then we talk about, all right, let's say in 3 months, we really revisit, is this therapy effective or not? And if it is not effective by that point in time, as defined by your symptoms, weight gain, and your objective markers of inflammation, then we need to be chatting about layering on some immunosuppressive medications potentially, okay? Our second objective, I want to discuss the data supporting the use of exclusive enteral nutrition for Crohn's disease. And this is the best studied thus far nutritional therapy approach for inflammatory bowel disease. And as I mentioned before, this is for Crohn's, not for ulcerative colitis. So exclusive enteral nutrition is a formula-based diet where you take formula of some sort to provide nearly 100% of your caloric needs, and you exclude standard foods from your diet. You're allowed to drink some water, and in some protocols, you're allowed to have some juice, for example. You can do this formula-based approach either by mouth or by nasogastric tube feeding. And importantly, this does not require some fancy schmancy IBD formula, okay? These can be your run-of-the-mill intact protein formula. Pediasure, Boost, Ensure, for example, are formulas that can be effective for this approach, okay? And this is effective both for providing calories in our patient population, oftentimes malnourished, and also it is specifically used to treat the inflammation, and studies in children suggest about 80% efficacy in being able to induce clinical remission of active inflammation for children with Crohn's disease, somewhere between 8 to 12 weeks. Okay? So I think a big elephant in the room is, so we are a pediatric institution, there are going to be some adult providers out here. So important, the adult data, and I'll be honest, it suggests that this exclusive enteral nutrition approach is less effective than corticosteroids. Okay? This is in contrast to the pediatric data suggesting that EEN is as effective as corticosteroids. I've got a little meta-analysis here, and what this means is you gather data from a lot of smaller studies, and then you collate the data, and you're able to make statistical conclusions that are more powerful when you have all of the data integrated. And as you can see here, if you're right at the line number 1 with that big dark diamond right there, it suggests that there's equivalence between corticosteroids and EEN. Okay? And this is a big deal to note that steroids, immunosuppression, and nutritional therapy, it looks equivalent in terms of outcomes here. To go into a specific study out of Italy that was really elegantly done and provides us good insight into what's going on. So in a study in Italy, they took 37 children with newly diagnosed Crohn's disease, and then they randomized them to a 10-week trial. One arm was corticosteroids for 10 weeks, and the other arm was this formula-based approach for 10 weeks. Okay? On the left here, we have clinical remission as our endpoint. Okay? This means symptomatic improvement. You see the EEN and steroids, they both had about 70 to 80% clinical remission, which is pretty decent. Okay? Nutritional therapy, improvement in symptoms, fairly equivalent. When they did colonoscopies for these kids to compare the healing of the GI tract mucosa, this is when a difference was visible. We see that for the formula approach, nearly 70% had healing of the GI tract mucosa. With the corticosteroids, though, we see 30% had healing. So interesting here. We need to follow objective markers of inflammation, and we see here that nutritional therapy for kids with Crohn's disease with this EEN approach was superior for mucosal healing. So what's going on with this story about EEN in adults here? So we think that adults are different than kids, and I know that I'll make my kid do things that I won't necessarily always do. So what's going on in adults? The adult studies have concluded that there's probably some lesser compliance in adults with Crohn's disease. They don't like the taste of ongoing formula, same thing for 6 to 12 weeks potentially, and the motivation sometimes to avoid medicines is just not there. Parents enforcing their kid doing something like this, slightly different than adult making the decision to do this on their own. Okay? In addition, adults have a longer disease duration, and it's likely that the inflammation was longer standing, and many adults had exposure to different medications prior to trying nutritional therapy. So their immune system was already tweaked and modulated by medications prior to trying nutrition. If you look at EEN in treatment-naive adults, so these are adults that have newly diagnosed disease, and in these two studies, there was an option of nasogastric tube feeding, so putting a tube in your nose to your stomach to help with the compliance and decrease the issues of poor palatability. Interestingly here, clinical remission, this looks strangely familiar to the pediatric data. Okay? Newly diagnosed adults, option of NG tube, there was clinical remission in the 80-ish%. Okay? I think EEN can be effective in adults. All right, so how exclusive do you need to be on EEN? Do I need to be 100% exclusive, or can I do like 50% of my calories from formula, and is there a beneficial effect? This is a study done out of the UK, and it shows PEN is partial enteral nutrition, 50% of calories from formula. And they call EEN TEN. I think the British folks always have a better way to say things, fancier. So that's essentially EEN. You look here at change in this clinical disease activity index score, you see that there was a lesser decline for 50% formula than for the total 100% formula, okay? So the 100% formula approach appears superior from this analysis, and this is what we believe. So this is a study that I did when I was in Philadelphia. It was called the PLEASE study, and it followed 90 kids over 8 weeks on 3 different types of therapy. And we collected biological samples with blood work, clinical disease activity indices, quality of life, and also microbiome over this 8 weeks, okay? And the 3 arms of this study were the partial enteral nutrition, 50% calories, the exclusive enteral nutrition, 100% calories, and then an anti-TNF alpha medication. This is a potent IV immunosuppressive medication in general, like infliximab or adalimumab. So in this study, we looked at outcomes at 8 weeks, okay? So I'm going to point out first the red bars, okay? The red bars are clinical disease activity remission. What proportion of each of these 3 groups achieved remission of the clinical disease activity index? So we see here that there's a difference between the partial group, PEN, and the EEN group. It is a significant difference, so it is improved in the 100% group, very similar to what the UK study found. We took it another step, and we looked at fecal calprotectin. Okay? This is a lab that you can check in the stool, and it is a surrogate marker of inflammation in the GI tract. When we looked at the outcome of fecal calprotectin less than 250, we see that there was a clear distinction between the partial enteral nutrition and the exclusive enteral nutrition. So about 15% versus 40%. Next, I want to talk about the comparison of immunosuppression with an anti-TNF alpha versus exclusive enteral nutrition. This analysis here, again, 90 patients, so the power of this study, the number of patients here, is not huge, but it's a good size. And we see that both clinical remission and that fecal calprotectin endpoint was not statistically significantly different between the two groups, which is interesting. Perhaps with a larger sample size, the anti-TNF would be somewhat superior. But in my mind, this is suggesting that the power of nutritional therapy is quite impressive if you can rival something like an anti-TNF alpha biological drug. This is a drug that's a synthesized antibody that binds to tumor necrosis factor alpha, which is an inflammatory cytokine. So what about the quality of life on nutritional therapies? So we don't really talk too much about this. We just say this can be a good therapy, but how does it impact my functioning? So in our study, again, this is looking at 50% formula, 100% formula, or the infusion of this medication. So we look here. If you see, the IMPACT score is a quality of life IBD tool. And if you look here, the total IMPACT score decreased for all of the groups, actually, which is great news. There were some distinctions, though. If I've highlighted in bold there, systemic quality of life was superior for exclusive enteral nutrition versus partial enteral nutrition. The other thing I'd like to call out is when you looked at quality of life associated with body image, the exclusive enteral nutrition group was superior to the anti-TNF alpha. Okay? And then the other thing I'll call out is when you call out treatment-associated quality of life, having to drink a lot of formula versus having IV infusions intermittently, we did not see a significant difference between the EEN 100% nutrition and the TNF alpha. Again, this is interesting to me. For some people, even though this is a burden on their life, they don't feel that it greatly impacts their quality of life because they see the benefits and the trade-off is worth it to them. So how can we think about using nutritional therapy in combination with immunosuppressive therapies? This is a cool study out of Japan. And what they did was they took 102 patients on infliximab, which is an anti-TNF alpha medication. And they put people in two groups. One was a group where they took 50% of their calories from formula, and in the other group, they did not take 50% of their calories from formula. And what this graph shows is everybody at the start of this study was in remission. By definition, to be in this study, you're in remission. So 100% remission at time 0. Going over 2 years, you see that the percent in remission drops, okay? But the blue bar group is the group taking 50% of their calories via formula. And the red bar group is not taking 50% of calories via formula. Okay, so I've mentioned before, 100% of calories versus 50% of calories, 100% clear winner. A question that arises is, can we use dietary approaches like this in addition to medications that suppress your immune system to achieve better outcomes? And in my opinion, the answer is a clear, resounding yes. We do have to do some work to think about what are the dietary approaches that we would employ alongside immunosuppression, though. Think formula, SCD, other exclusion diets. I think those are all in the mix, and we need to better study them. All right, so what do? You're on this formula-based approach. How do you transition off of this, and where do you go? I think there was a great question about how do you transition from EEN to the specific carbohydrate diet. I want to talk a little bit about that. So in my mind, if you're a medical practitioner here in the room, and you are going to be guiding somebody on nutritional therapy with formula, exclusive enteral nutrition, you need to have an exit strategy as soon as you're beginning to employ this diet, okay? Different options are starting an immunosuppressive medication, transitioning to a whole food-based exclusion diet, or some people opt to continue EEN formula long-term because other therapies are not working. So these are 3 different approaches you can take. Our third objective, discuss the use of the specific carbohydrate diet in clinical practice. I'm going to veer from this objective a little bit. I want to talk about other exclusion diets because I want to be fully honest. SCD is the best studied diet, and we see efficacy, and I employ this. But I do think we have a lot of opportunities to learn. In my opinion, SCD is not the magic bullet. Yeah, we will learn more about which components of SCD are the most important, and some of these other studies give us insight, I think, and can advance us so that the SCD can be potentially slightly more liberal for particular patient populations. So, different food-based dietary therapies. Dr. Susskind talked about SCD, and I'm going to reserve that for the last portion of my talk. There's the Crohn's disease exclusion diet out of Israel, and I will show you some data from there. Semi-vegetarian diet's been studied in Japan. The CD treat diet has been studied in the UK, really cool sort of way they approach this, and I'll talk about that. And then there are a plethora of anti-inflammatory diets that people have attempted to employ. So some of the common themes with these exclusion diets. So commonly you exclude bread, gluten, and processed foods. Learned a little bit about what processing means. There's quite a bit of variance in these diets and how much dairy they say you have to take out, sugar, and animal fat stipulations. The Crohn's disease exclusion diet. This is Dr. Ari Levine's group out of Israel who studied this. And what they've done is a special diet plus 50% of calories from formula and look to see what effect does this have on Crohn's disease. So with this diet, they chose a polymeric formula, which means an intact protein formula for 50% of kcals. And then they specifically stipulated excluding these different food groupings. So gluten, gluten-free baked goods, dairy, all dairy, animal fat, processed meat, emulsifiers as a broad category, canned goods, and all foods with an expiration date. Okay? So they've described this, but they have not fully published on exactly the details of this diet. So they have some very interesting results here. So they looked at C-reactive protein, a blood marker of inflammation, and they saw that over 6 weeks that there was decline in this. In addition, they looked at the pediatric Crohn's disease activity index, and over 6 weeks, again, you see a nice downtrend. So this is an interesting diet that is being further studied. A semi-vegetarian diet was studied in Japan, and this is, to get into this study, you had to have Crohn's disease in remission, and it was put into remission either by medications or with surgery. And then the end point of this study was, did you get into disease relapse? So with this, they used a 5-amino-salicylic acid, which is a non-immunosuppressive medication used for IBD. You can think of it as sort of a topical anti-inflammatory, and a semi-vegetarian diet. This diet was defined as allowing eggs and milk, fish only once per week, and meat every other week, okay? Thus the semi-vegetarian. It stipulated avoidance of sweets, bread, cheese, margarine, fast foods, carbonated beverages, and juices. So what this study showed was, again, small study, but 15 out of 16 subjects on this semi-vegetarian diet maintained clinical remission, okay? Whereas 2 out of 6 on the ad-lib eat-as-you-like diet maintained clinical remission. And I will point out one weakness of this study is they're looking at clinical remission as opposed to objective markers of inflammation. But in my mind, this is, again, suggestive. It's provocative. Using a dietary intervention clearly has an impact on disease pathogenesis and course over time. The CD treat diet. I really like this study. I think it's clever. So their hypothesis, this UK group, Konstantin Gerasmidis, so they really wanted to examine sort of how does EEN work. And what they did was they used modulin formula, which is a commonly used formula in Europe for EEN. And they had some smart dietitians figure out which regular food components can we use to mimic the nutritional sort of contents of modulin formula, okay? So they were like, we can use regular whole foods and get sort of the same nutrient profile as formula. Let's see how that works. So in their diet, they avoided gluten and lactose. They matched macronutrients, vitamins, minerals, and fiber to the modulin formula. And then they had these foods delivered by a catering company to individuals. So there were really 2 main clinical arms of this study. They tried this study in 28 healthy adults, and they found that the microbiome changes with this ordinary food-based diet based on the formula were actually very similar to the changes to the microbiome seen when people took the formula. So you can get similar microbiome changes with formula or whole foods that kind of mimic the contents of the formula. Okay? They also did a study in 5 kids with Crohn's disease. Again, a small study, but they found that the 5 kids with Crohn's disease who were on this ordinary food diet based upon the contents of the formula, that there was improvement. The improvement, though, I think needs to have an asterisk. So this is fecal calprotectin. Again, surrogate marker of intestinal inflammation. So in general, we tend to think that a level less than 100 micrograms of fecal calpro per gram of stool is in the normal range. Okay? These kids clearly had inflammation at baseline, somewhere like around 2,000 as a starting calprotectin. At the 4-week mark, they dropped to about 1,000, and at the 8-week mark, they stayed at 1,000. In my opinion, the great success is there was nearly 50% reduction in stool marker of inflammatory burden, but there was not induction of remission here. So clearly there was residual inflammation, so there was a benefit, but we didn't get into full remission here. So a study that Dr. Susskind has mentioned that we are doing here, and Dr. Van Amel is part of this study as well too. So we had kind of a similar hypothesis, and we're attacking this with a slightly different approach. So we think that a whole food-based smoothie, and I'll call out all of our GI dietitians are part of this study too, a whole food-based smoothie can effectively induce remission of Crohn's disease. So make a smoothie out of whole foods that emulates the nutritional contents of the common formulas we use for EEN. We would like to study to see if we can induce remission with this approach. So our study is a 4-week study for children with active Crohn's, and we follow symptoms, markers of inflammation, blood, urine, and stool over this course of time. So our intervention is a smoothie that was developed in my house at our smoothie lab. So we've had food scientists, chemical engineers, dietitians, and GI docs that have been part of this little effort. So we have a little recipe right now. And for this, families, if they enroll, are given a Vitamix blender, and they're shipped all of the food contents that they need for the duration of this study. There's an option to continue all the way until 8 weeks. This is a small study. Our goal is to get to 10 patients, but really to push the understanding of how can whole foods be used to emulate the very clear-cut success of exclusive enteral nutritional therapy. So specific carbohydrate diet, Dr. Susskind has talked about this, and Heather and Talia are going to go into more detail. So I won't go into too much detail here, but clearly there's a huge following in the IBD community out there. Anecdotal evidence is very plentiful, and case series are very, very provocative as well. So we have seen this work for our patients. This is just a quick overview of the classic stages of the specific carbohydrate diet. So you start with very, very easy to tolerate foods, and then you kind of go to more sort of a whole foods, unrestricted SCD. Here at Seattle Children's Hospital, we don't really advocate going really, really slowly through these stages, but we try to get people to the stage 5 pretty quickly, and Heather will touch on this. Dr. Susskind showed this. I want to take a little different angle here. So this is the study Dr. Susskind showed. It was a survey of people who had IBD who used specific carbohydrate diet therapy. As you can see, over the different months, 0, 2, 6, 12, there's a decline in these symptoms. What I would like to point out is really important is in this study, only 17% of 400 plus participants for the study said they had guidance from a healthcare professional. So people are doing this on their own, like it or not. In my opinion, I commend these people for trying to take advantage and utilize diet as therapy, but we as medical professionals, we really need to be part of this, partner with our patients, and provide guidance on how do we look for appropriate endpoints of disease remission, disease activity, and for our dietitians in particular, helping to guide nutritional adequacy and also successful implementation of this as a therapy. Again, it's similar to Dr. Susskind. I'll take a little different take as well. There are numerous studies that have demonstrated success for this specific carbohydrate diet therapy. So these studies have looked at weight gain, they've looked at clinical disease activity, they've looked at markers of inflammation. So these are all quite suggestive. But as you can see, these studies are small aside from our patient survey. Okay? Dietary studies are a little bit hard to do, and thus the smaller numbers, but we're really lucky. Dr. Susskind is leading the PRODUCE study, this N of 1 SCD study versus modified SCD study in kids with Crohn's disease. And then my mentor at the University of Pennsylvania, Jim Lewis, he's leading an adult study called a DINE-CD, and it's looking at specific carbohydrate diet therapy versus the Mediterranean diet. They will ship you all foods and snacks for a 6-week period of time. I think these studies will be eye-opening and really good, but I would caution for the adult study, when you provide people food, versus if somebody has the incentive to do this on their own, there may be some differences in compliance and choices of dietary intake. So I think it is one caveat caution with studies where you provide food. So which exclusion diet should I choose as a practitioner? So exclusion diets have clearly demonstrated efficacy, and there are some good studies ongoing. Our practice at Seattle Children's is to use exclusive enteral nutrition and then bridge to other therapies. And we also are strong proponents of this specific carbohydrate diet. We do know that more studies are needed. So back to our case. So JW, so he's a 14-year-old male with newly diagnosed ileocolonic Crohn's disease. And as you can remember, parents were a little bit hesitant given the history of lymphoma for this child. So they wanted to be on exclusive enteral nutritional therapy. We gave the option of an NG tube. The child said, I'm gonna drink it by mouth. And boy, was he a champion. So he worked up to his goal of 9 shakes. I think formula versus shake. I think a shake is nicer to say. So 9 shakes per day over a 1-week period in time. We calculated nutritional needs with the help of our dietitian, and there was improvement in symptoms. Diarrhea got better, abdominal pain got better, and then over 8 weeks, he gained 12 pounds. So he did a great job. He was missing salty foods and snacky foods, though. After 8 weeks, the decision was made to gradually transition to the specific carbohydrate diet therapy, and this child had demonstrated that he was a responder to nutritional therapy. So he was transitioned over to the specific carbohydrate diet therapy with very, very close follow-up and support from our dietitian team, and he's currently maintained on specific carbohydrate diet therapy. We are very, very careful to follow markers of inflammation and growth, but he's doing clinically well. So what was his follow-up schedule? So when he was on specific carbohydrate diet, there was sort of very close follow-up with the dietitian. So as you can see here, this is sort of initially 2 weeks after the starting specific carb. We had him come back and see a dietitian just to really make sure that things were going smoothly. At the 1 month mark, met with doc as well as dietitian. We did blood labs. We wanted to see if markers of inflammation were at all more worrisome, and we followed stool calprotectin as well. Again, same thing at week 8, week 12. And thereafter, after things had demonstrated some stability, we are seeing him every 2 to 3 months. And at some point in time, he will get a scope to really assess for mucosal healing as well, too. So what parameters should I be monitoring if I have a patient on a dietary therapy? So the clinical symptoms are important. So GI symptoms, belly pain, nausea, vomiting, frequency of stooling, blood in the stool. Weight is an important clinical parameter. Energy. Is my patient just really drained? Maybe he's not getting enough of certain nutrients, vitamins. Psychological well-being. Is this an effective therapy at driving in remission, but is this child withdrawn and unable to function socially because of this restriction diet? There's a sort of an important discussion that needs to happen here. Okay? And labs. Blood counts, inflammatory markers, albumin, which is again a marker of inflammatory status, Calpro, and then again, vitamin D is important to follow, specifically on the specific carb diet, because much of our vitamin D is from commercial dairy products. In conclusion, implementation of dietary therapy is totally doable, but it requires a thoughtful discussion between the medical team, patient, and the family. Both EEN and specific carb diet, as well as these other exclusion diets, have demonstrated efficacy with treating active inflammation in IBD. I think this is a really important point. If I could say one take-home point from my talk, really partnering with the medical team is critical if you have patients on nutritional therapy, okay? There is a tendency sometimes for these families to really take charge and not follow up with their medical team, and sometimes we see them come in and the child is extremely ill, okay? And then I will say, full disclosure, we need much more studies on diet and IBD, and we're very fortunate to have great partners in the room today, and for our patients and families as well too. They have been phenomenal in supporting our research, so a huge thank you to them. With that, I'm happy to take any questions. We have mics. Would you like a mic?
Sure, if I can project.
I think they're recording this.
Oh,
so
I see.
for the people that might want to hear.
Great. My question is about transitioning from enteral therapy to SCD. I'm mystified by it, to be honest. I'm a dietitian in Portland. And I have a couple of patients who are enteral therapy and they're wanting to go to SCD. And I've read all different styles. So can you comment, and maybe Heather will comment on it too.
Yeah, Heather's going to be more hands-on. I'm going to bring up something that I glossed over very quickly. If you look at exclusive enteral nutrition and compare the nutrients and food additives and processing versus specific carbohydrate diet, it's like black and white. You're like, what's going on here? Dr. Susskind did a nice job demonstrating that with using a dietary therapy like SCD, there is improvement in dysbiosis. With exclusive enteral nutrition, he demonstrated there is worsening dysbiosis. So sort of the mechanism by which these therapies is effective is probably a little different. And if you look at any commercial formula used for exclusive enteral nutrition, you'll see maltodextrin, you'll see soy lecithin, and oftentimes you'll see carrageenan as well too. So it's, again, there's a distinction here, but clearly the idea, the concept that's important is by making a rigorous dietary intervention and excluding certain foods, we can see improvement. in terms of the practical of going over from something like a exclusive enteral nutrition diet to a SCD, I think partnering and thinking about sort of a graded introduction is probably the best way to go. I don't think dropping EEN cold turkey and going straight to SCD is the right thing to do. What I would suggest is, for example, starting by 20% of calories per day from specific carbohydrate diet, okay? With a gradual increase up to 50% over like 1 to 2 weeks, and then thereafter liberalizing over the next 1 to 2 weeks, and then going to straight specific carbohydrate diet. You'll find it very funny, maybe. I find it amusing. So formula is illegal on the specific carbohydrate diet. So there's a little bit of there's a dichotomy here, but we know that these dietary therapies are effective. So it's sort of a little bit played by ear, and you want to make sure that sort of nutritional adequacy is there. And in general, after 6 to 8 weeks of EEN, people are itching to eat. So giving them the right guidance about which kind of foods to eat. And to be honest, it's sort of the perfect setup. You've had all these foods taken out of your diet, and to transition to a restricted SCD diet, you're going to be loving that you can eat anything. So maybe that is an easier transition than going from cold turkey, eating my Western diet, to specific carbohydrate diet.
Can I add one thing?
Yeah, please.
So I think that, as Dr. Lee has mentioned, we need so much more research to really know the best way to move forward. And I think the approach Dr. Lee takes is very appropriate and for all intensive purposes correct. I will say that my approach is just transitioning them straight to SCD. And that brings up your point, which is you read a lot of different things, and a lot of people are doing different things. And there isn't an absolute right or wrong way at this stage. It's really what our patients showing us. In my mind, if you've reached remission on EEN and you're maintaining on the SCD, and we know the SCD works, a quick transition is okay.
Yeah,
but
totally
more research.
Yeah, totally agree with Dr. Suskin. I think it's very fine to do an immediate transition. The other important thing is when you are in disease remission, you're probably going to be in remission for a while. So to be able to, when you're in remission, it's easier to stay in remission. The getting into remission is the heavy lifting piece. So again, we have slightly different styles of getting over to SCD. Either is fine. Yes.
When you're doing the transition from EEN to SCD, are you doing inflammation markers, like, again, to see if adding whole foods affect the inflammation even
Absolutely.
though it's SCD?
Absolutely. Again, the mechanism of action is a little different for EEN and SCD. And some people have great response to EEN and SCD doesn't work. So following them very closely is important. So I think as a dietitian, making sure there's nutritional adequacy, the kid doesn't feel hungry, and also making sure as a practitioner that you're following the inflammatory markers very closely. So important.
Hi, thank you very much for that. One of my questions is, what is the maximum period of time that you would keep somebody on EEN?
It's a great question. So some people, in my practice, I've had some people opt to get a gastrostomy tube placed and use it long term because they have failed every medical therapy that was available at that point in time. There are a lot of new medical therapies being developed right now, so we're thankful that there are new options, but for some people, medicine does not work well. So some people opt to do this as lifelong therapy. I didn't get into this, there's some discussion about, can you do sort of this graded form of EEN? So some people have suggested that to do maintenance therapy with EEN after you've driven things into remission, that you could do like maybe 5 days a week, or maybe 4 days a week, or maybe like 1 month on, 3 months off, something like that. So there's not good data here, but some people will opt to continue full on EEN long term, or more commonly I see some people opting to do partial enteral nutritional therapy long term. When I did my slides comparing EEN and the partial to 50%, that's for induction of remission. Okay, so EEN far superior for induction. For maintenance in remission, the data is not quite as strong, but it's suggestive that maybe partial enteral nutritional therapy can be used.
In your institution, you have very dedicated medical staff and highly motivated nutritionists support. I know how much of time and effort it takes to keep them in the nutritional therapy. With this strong foundation of these two backbones, approximately what percentage of your patients follow nutritional therapy? What percentage goes to standard treatment, what we all do?
Yeah, Dr. Susskind, do you know the data? I'd say in my clinical practice, probably, I'd say standalone nutritional therapy, probably like 20%, 15 to 20% of my patients. Concomitant making nutritional interventions plus medications, above 50% of my patients do. Some people clearly are like, I don't want to do the nutrition, please. Let's talk about medications. In my opinion, that's okay. If there are problems that arise, then we need to think about what additional meds to add on or layer on dietary changes. But Dr. Susskind, what are your experiences?
No, very similar to yours. I think we see 10 to 20% doing SCD. I'd also say that we're very proactive in terms of education. We don't necessarily tell people to do dietary therapy, but when we make a diagnosis, we lay out all the options, medications, nutrition therapy, EN and SCD, and for those who want it, we support. But the numbers you have are very similar to mine as well.
Two questions. First one about mucosal healing, if you can share some data about how often you reach that on SCD or EN. The second question is, I think you mentioned that, but to confirm there's no difference between elemental versus polymeric formula.
Correct. I'll answer the second question. It's easier. So elemental formula means formulas that have the protein broken down to amino acid level. Versus intact cow's milk protein formula. So the data shows that there's no difference in outcomes. In Japan, they use this formula called Elental, which is an elemental, and they just have used that traditionally over time. The studies, again, show that there's pretty good 70 to 80% efficacy at induction of remission, regardless of the formula type. The amount of fat that's in there and the carbohydrate content. So it's not that there's some particular special formula. I think it's the concept of sort of, it's maybe the liquid, maybe it's the antigenic monotony, maybe it's the exclusion of foods. There's a lot of, or changes to the microbiome. There's a lot of hypotheses about how this works. Your first question is a little harder to answer, the mucosal healing question. So that study out of Italy was a very nice demonstration of mucosal healing. For specific carbohydrate diet, we have not done a really rigorous trial here at Seattle Children's looking at mucosal healing as an outcome. As you can imagine, people don't love volunteering for scopes often. If they're doing clinically well, growth is good, inflammatory markers are perfect. But we do need that data. There are some studies, I think the Stan Cohen study, where they looked at, you did a pill camera and you looked to see what the status of the ulcerations were. That demonstrated mucosal healing. But we do need more data on mucosal healing. Sort of the movement in adult IBD trials is to really assess mucosal healing. And as you can imagine, drug companies can fund a study where they fund the repeat colonoscopy, for example, at the end of the study. In children, we are mindful about not doing anesthesia and risky procedures sort of too frequently for kids. So it would be difficult to sort of say, all right, at the end of 4 weeks or at the end of 8 weeks, we're going to scope you to really assess for mucosal healing. The one thing we do use is the stool calprotectin. So what calprotectin is it's a neutrophil cytoplasmic protein. So neutrophils are inflammatory cells. So if you have a lot of inflammatory cells, neutrophils in your gut, those things will break down and you'll be able to measure fecal calprotectin. And studies have demonstrated a nice correlation between stool calprotectin and endoscopic visualization of inflammation.
Can you expand on how in the world EEN actually works to induce remission, considering how inflammatory the ingredients are in the formulas?
Great question. I think how inflammatory the ingredients are is, and I think an interesting way to phrase it. So this was first discovered to be effective in the 1970s. So adults with Crohn's disease were on surgical units and they could not eat or drink. And this was like sort of before the advent of IV nutrition or TPN. surgeons, there's one surgeon, his name is Vodik. He placed a nasogastric tube in these guys, and he just did little trickle feeds because he wanted to nourish them because they were wasting away. So interestingly, he found that in his surgical ward with really bad Crohn's that was like really strictured stenosed, these people couldn't eat. There was no way. They were withering away. He found that nutrition with just drip feeds with the tube helped these people gain weight, and very interestingly, their inflammatory markers improved. This was sort of the first time it was seen that nutritional therapy with EEN could be effective, and clearly it's been rolled out much more broadly than that. We don't know the exact mechanism by which EEN works, but in terms of the studies and the rigor of the studies out there, EEN far supersedes any exclusion diet at this point in time. If I were to hypothesize mechanism of action, Dr. Susk and I talk about this a lot. I think one thing, microbiome is key. So something is shifting in your microbiome. I think some emulsifiers have been demonstrated to be clearly problematic. So Dr. Susskind mentioned polysorbate 80, carboxymethylcellulose. Those have been demonstrated in basic science models to be problematic. Sort of thinning of the mucus layer, increased sort of closeness of the bacteria to the epithelial cells. Soy lecithin, though, has not been demonstrated to be problematic. One common misperception people have, they say, an emulsifier must by itself degrade that mucus layer, so a direct effect on the mucus layer, but that's not the case. If you take a germ-free mouse, so mouse with no bacteria in the intestines, and you give them emulsifier, there is no change to their mucus layer. But if you give a mouse that has a microbiome, that emulsifier, then there's a change that occurs. So like Dr. Lampe mentioned, like Dr. Vanamela mentioned, there's something that happens when you feed something, the gut metabolizes it, and then there's something else that's produced, and that seems to be problematic. So there's something happening at the cellular level that we don't completely understand well. And if you look at these formulas for EEN, there's a lot of sugar in those too. So there's a lot of work to be done for us to understand the mechanism by which these therapies work. And we're hoping that our reverse engineered EEN smoothie trial, it's going to be a little different than the contents of EEN. There's going to be no additives. We did try to match the sugar content. We wanted to be macronutrient equivalent if at all possible. So a lot of work, but really great question. Okay, we'll do a couple questions. I think we have to break for lunch.
So I'm a dietitian, and I've worked with a variety of GI providers, and I feel like I've heard some differing opinions about exclusive enteral nutrition. There are some providers that said that you can provide 10% of calories coming from food and still induce remission, and sometimes it's the 100%, and we sort of go back and forth, and I've done it differently depending on the provider that's seeing the patient. So I wasn't sure if you had an opinion on that, or
I have an opinion, yes.
Okay.
And I'm glad you guys are having that dialogue. So for some people, it is just not, you just cannot do 100%. It just does not work. And in my opinion, it's likely the case that the more exclusive you are, the better. At least that's what the data is saying. But sort of what specific carbohydrate diet is teaching us and what other exclusion diets are teaching us is maybe there are whole foods that are okay to eat with this, okay? Like that Crohn's disease exclusion diet thing, that was 50% formula and 50% food. I think we can get there, but the data, if you're going to sort of say data-driven, what's the best way to get to the highest likelihood of remission? It's 100%. In my practice, I will bend. I will use 20% of SCD plus EEN for certain patients. So I think that is okay. What I would suggest is, okay, you got to follow up real closely, see what the markers of inflammation are. And if they're not getting better, you may say, okay, we need to transition to meds, or are we going to transition to 100% and see if that's the key?
But you're only using SCD foods for those 10, 20%.
I think that's what I would recommend right now, and I think more studies to be done.